is ready for his presentation, I think we can start the case. Can I please know who is the other panelist or the expert?
Ma'am, they are joining in few
Okay.
moments.
So can we start the case,
Yes.
or we should wait?
Ma'am, we can start. He will
Okay.
join in 5 minutes.
So Dr. Shirish, please start your presentation.
To lower middle class, Hindu by religion, and a resident of Mahara Sonipat. He presented with chief complaints of right-sided nasal obstruction since 12 months, and patient also had complaints of external nasal bulge since 6 months. History of presenting illness. The patient was apparently asymptomatic 12 months back when he developed right-sided nasal obstruction, which was insidious in onset. It gradually progressed to the present state. Nasal obstruction was complete, persisting throughout the day. It was increased while lying down. There was no relief with medication in the form of oral tablets and topical drops, and there was also no diurnal variation present. Patient also mentions 5 to 6 episodes of right-sided nasal bleeding, which was only initiated when the patient used to forcefully blow his nose or used to pick his nose. Bleeding used to continue for a few minutes and was around a spoonful in amount. It was relieved on pinching the nose, and the last episode of nasal bleeding occurred 1 month back. It was associated with hyponasal voice. Patient also complains of a bulge on the right side of nose since 6 months. It was insidious in onset, gradually progressed to the present size. There were no complaints of any pain or redness in the swelling. There was no history of discharge from the swelling, no history of sudden increase or decrease of the swelling. There was also no change with coughing or straining. There were no aggravating or relieving factors. There was no history of any nasal discharge, no history of recurrent episodes of runny nose, itching, sneezing, and watering eyes. Patient also had no history of pain or recurrent clearing of the throat. There was no history of recurrent episodes of headache or facial pain. There was no history of numbness of face or loosening of teeth. There was no history of earache, decreased hearing or ear discharge, and there was no history of eye swelling, decreased vision or pain in eyes. Patient also had no history of loss of weight, decreased appetite, or evening rise of fever. Then the past history. There was no history of similar complaints in the past, and patient is not a known case of diabetes mellitus or not a hypertensive. There was no history of asthma or tuberculosis. Patient has no history of any previous nose surgery or no history of allergy to drugs. Treatment history. There is no history of any previous hospitalization, any long treatment, or any previous surgery. Patient consulted ENT department of BPS GMC 9 months back, after which patient lost follow-up and has presented again for the same complaint. Family history, there is no significant family history of any similar complaints in family or any other chronic illness in the family. Personal history, patient is a vegetarian with taking adequate diet. Patient's appetite is normal. Patient has a normal sleep cycle. The bowel and bladder movements are regular. There is no history of any tobacco chewing or smoking. Patient was a chronic alcoholic but has quit drinking 14 years back. General physical examination. Patient is conscious, cooperative, and well oriented to time, place, and person. Patient is moderately built and nourished. His vitals are the pulse rate is 80 per minute, 80 beats per minute in the right radial artery, which was regular in rhythm, character, and the condition of vessel wall was normal. All peripheral pulsations were felt equally. bilaterally, and there is no radial or radiofemoral delay. Patient's BP was 138 by 80 millimeter of mercury in right arm sitting position. His respiratory rate was 16 breaths per minute. Temperature, patient was afebrile to touch. Uh, there was no pallor, icterus, clubbing, cyanosis, generalized lymphadenopathy, or edema. Coming to the systemic examination, is in the CVS examination, S2, S1 and S2 sounds were normally heard and there were no murmurs. Respiratory system, there were normal vesicular breath sounds with no added sounds, and abdominal examination showed soft and non-tender abdomen with no organomegaly. CNS functions were intact and there was no focal neurological deficits. Then the nose examination, the external osteocartilaginous framework. On inspection, there is a diffuse bulge of around 3 by 2.5 centimeter present on the right side of the dorsum, obliterating the right nasofacial sulcus. There are no visible pulsations noted. There is no cuff impulse present. The skin over the bulge appears normal in color. There are no sinus, scar, any puckering present over the swelling. On palpation, there was a bulge measuring 3.2 centimeter into 2.5 centimeter with no tenderness or local rise of temperature over it. It was firm to hard in consistency. The surface is smooth. Margins are indistinct. It was non-fluctuant, not compressible, non-reducible, non-pulsatile. It cannot be moved over the underlying structures, and the skin above the swelling is free. The root, bridge, left side of the dorsum, tip, columella, and bilateral ala are normal in size, shape, and structure. On tip elevation, bilaterally vestibule was normal, and there was no caudal dislocation present.
Shirish, you have a picture of the patient here. Yeah.
Yes, ma'am. Yes, ma'am.
The yes, you.
This is the bulge on the right side, as we can see. Bulge on the dorsum and also obliterating the nasofacial sulcus. On tip elevation, the vestibule is normal, no caudal dislocation, and we can also see the nasal mass. On anterior rhinoscopy, on the right side, the mucosa was congested and the inferior turbinates were not visualized because the mass was almost approaching the vestibule. The septum on anterior rhinoscopy, only the anterior most part of the septum was visible.
Again, to your picture, the which you have shown in the last slide. Just show
Ma'am.
us that again.
Yes, ma'am.
So this is the picture. Everybody should see and then later on.
Then
Okay.
this
Now,
is the external bulge and the patient, the bulge and the right-sided nasal mass. Ma'am, should I carry on with the next slide?
yes. Yeah.
Yeah, yes. Septum, only the anterior most part was visible on anterior rhinoscopy. In the nasal cavity, there was reddish smooth mass seen filling the nasal cavity up to the vestibule. The inferior turbinate, middle turbinate, and most of the septum cannot be visualized. On probing, controlled probing was done. It is sensitive to touch. The consistency of the mass was firm, and probing can be done all around the mass except at its attachment to the septum. Along the septum, it was the probing could not be done, and while trying to probe, bleeding started. Then the floor of nasal cavity cannot be visualized on right side. On left side, the mucosa was normal, inferior turbinates were normal. Septum had, there was a septal spur present, which was impinging the adjacent part of inferior turbinate in the mid nasal cavity. The rest, nasal cavity and floor was normal on the left side. Then the functional test. The cold spatula test was there was no misting present on the right side, and left misting was seen. On cotton wisp test, there was no movement on the right side, while there was movement seen on the left side. Cottle's test was negative. Smell test, on smell test, the patient had normal smell sensations. On posterior rhinoscopy, bilateral choana are free. Posterior end of the bilateral middle turbinate and inferior turbinates were visible and were normal. Bilateral eustachian tube orifices and the bilateral fossa of Rosenwiller are normal. Examination of paranasal sinuses. The inspection reveals no swelling or redness of skin over the sinuses. On palpation, there was no tenderness present over frontal, maxillary, ethmoidal sinuses. Then ear examination. The preauricular area was normal on the.
Wait for a minute. I just
Yes, ma'am.
want to inquire about other panelists, whether they've joined. Any other person is joined or not as panelist? You can continue.
Ear examination. Preauricular area was normal. There was uh, preauricular area was normal on right side. The pinna was normal in size, shape, and position. Postauricular area was normal on right side. Uh, the tragal sign was negative. External auditory canal was normal and it was clear, and tympanic membrane was intact. There was no mastoid tenderness seen. On tuning fork test, on just Renee's test was positive on right side, and Weber's was centralized. On absolute bone conduction, it was same, and the sounds were here heard same as examiner. Facial nerve function was normal, and there was no spontaneous nystagmus seen. On the left side, similar findings were seen. The preauricular area was normal, the pinna was normal, postauricular area was normal, and the tragal sign was negative. External auditory canal was normal. Tympanic membrane was intact, and mastoid tenderness was absent. Tuning fork test showed positive Renee's test with uh, all three tuning forks. Weber's was centralized. Absolute bone conduction was same as examiner. The facial nerve function was normal on left side, and spontaneous nystagmus was absent. Then coming to the examination of oral cavity and oropharynx, the mouth opening was adequate, orodental hygiene was adequate. The lips, labial mucosa were normal. Gingivolabial or gingivobuccal and gingivobuccal sulcus were normal. Patient was partially edentulous. The buccal mucosa, bilateral, retromolar trigone, hard palate, soft palate, uvula, tongue. The anterior two-third of the tongue and posterior one-third of the tongue was normal, and the tongue movements were also normal. Bilateral anterior pillars, posterior pillars, tonsillar fossa and were normal, and posterior pharyngeal wall was normal. On neck examination, larynge, laryngeal framework was normal, and laryngeal crepitus was present. There was no cervical lymphadenopathy, and the trachea was central. The examination is complete. Should I read the summary?
This is the summary. Yeah, read out the summary, then we'll go with the questions.
Ma'am. A 46-year-old gentleman presented with a complaint of right-sided nasal obstruction for 12 months. The obstruction was insidious in onset and gradually progressive. It was more on lying down. It was associated with intermittent episodes of nosebleed. The patient also had a right-sided external nasal bulge. On examination, anterior rhinoscopy revealed a right-sided reddish smooth mass On probing the on probing the mass, it was firm in consistency, and it could be probed all around except except along the septum. It was sensitive to touch, and on probing, on trying to probe along the septum caused bleeding. Ma'am, it's,
The summary.
yes, ma'am.
I just want to know again from NB people, is Mr. Navneet there online?
Dr. Uma, I think
Yeah, there's no
got
other
it.
panelist, Mr. Navneet today. Summary which
Yes, ma'am.
Dr. Shirish has presented of a case 46-year-old male, right-sided nasal obstruction. And in your history, we can go back to the slides again. If you can start it from the beginning,
Ma'am.
because I was waiting for the other panelists to join.
Yes,
Age 43 years. Okay. Right-sided nasal obstruction since 12 months and external nasal bulge since 6 months.
ma'am. Yes, ma'am.
Okay. You had said that patient is having consultation at BPS since 9 months or 9 months back he had come.
Months
Because it's,
back, patient consulted, and after that, he lost follow-up. From those,
he lost follow-up. So we do
yes, ma'am.
not have any records of at that time what the patient presented with or what problems patient had. 9 months back means when he was already having nasal obstruction since 3 months.
Ma'am, patient had no previous records, but the last consultation, ma'am, patient was having documents of the last consultation.
Uh-huh.
Patient was
So at that
advised by,
time, the
yes, ma'am.
only complaint was nasal obstruction.
Yes, ma'am, the bulge was not present.
Bulge was not present.
Yes, ma'am.
Okay. So with the right-sided nasal obstruction since 12 months, if you go, and external nasal bulge since 6 months.
Yes, ma'am.
And no, the next slide. Just show me the next slide.
Ma'am.
Right, so it gradually progress, nasal obstruction, no relief with medications, no diurnal variations. And on in examination, you said important finding on probing. You said one word, controlled probing.
Ma'am,
So with controlled probing, what do you mean by controlled probing?
ma'am, any patient, if a patient has a complaint of nasal bleed, then ma'am, we won't straight away probe it. We'll gently probe it to avoid to whether see first whether to first see whether it has a any bleeding mass. Mm,
No, but the patient already had history of bleeding, no? So it's a bleeding mass only.
yes,
So
ma'am.
what do
So
you mean by controlled bleeding? Should it be controlled bleeding or you want to say on gentle probing? What do you want to say?
ma'am, it should be very gentle, ma'am. We should be very gentle, and we should be always ready that we should be ready that the mass may bleed anytime, and
Hmm.
so just gently we
So
have to,
which instrument did you use for probing?
ma'am. I used a Jobson's probe with the cotton carriers side,
Do you
along with,
apply the cotton to
yes, ma'am,
probe
with,
such a
yes,
mass?
ma'am,
Should
ma'am,
always apply
cotton,
cotton and you can moisten it.
yes, ma'am, it should be moistened.
Moisten it a bit. And did you use some anesthesia for it?
Ma'am, for probing, I did not use any anesthesia.
Any anesthesia because that would,
Ma'am, um,
because probe also tells us about the sensitivity of the mass.
we need to know the sensitivity also. Yes, ma'am.
So that is why you don't use any local anesthesia.
Yes, ma'am.
But you can use decongestant
Ma'am.
or no?
Yes, ma'am. Decongestant, ma'am. Nasal drops can be used.
Ah,
Xylometazoline or
yeah.
yes, ma'am.
So that will decongest the mass. The mass would become, it will shrink a bit. It can
Yes,
be easier and more convenient to probe it,
to probe it. Yes, ma'am.
right? So it should be gentle probing. I don't think, and there, if there is any word known as controlled probing. Have you got this word from somewhere, or just want you wrote
Ma'am,
it?
ma'am, actually,
I think. Yes.
ma'am, I took it from some other
Hello.
exam. Good evening, sir.
Yes.
Hi, Uma.
Hello. Hello. Hello.
जी,
Ah.
I
Yes.
just got it.
So
So can you summarize the case for me?
yeah, Dr.
Yes, sir.
Shirish, please summarize
Yes, ma'am.
the case and important points in history as
Yes,
well
yes, sir.
examination for Dr. Ishu Singh.
Yes, sir. Good evening, sir.
Good
Sir,
evening.
this is a case of Mr. Narendra, 43-year-old male, presented with right-sided nasal obstruction from 12 months and an external bulge on the right side from 6 months.
Hmm.
Pa- Patient had, sir,
Just
the
summarize,
nasal
summarize.
obstruction. Yes, sir. Pa- So the patient also had history of on and off nasal bleed along with obstruction,
Hmm.
and since 6 months, patient developed a nasal bulge, and there was no other external findings except the bulge and the on
Show the
examination.
call.
Hmm.
Yes, ma'am.
Right.
So, so patient had a right-sided external bulge on the dorsum obliterating the nasofacial sulcus.
Hmm.
Uh, there was a right-sided
Yeah, I could see there is
reddish,
a mass. Hmm.
reddish smooth mass, sir. It was almost approaching the vestibule.
Hmm. So go ahead with your examination now.
Probing.
You are probing the mass. I heard you.
So,
Hmm. So
yes,
what is
sir.
Tell the
the
So
findings
should
intention
I
of
of
probing.
probing?
read the
What
examination?
information you get after probing?
Probing consistency.
What are
Probing
the
could be done
information
on
you get
except
after doing probing? Tell.
yes, ma'am, we can see whether the mass is, first of all, we can see whether mass is a bleeding mass or not. As soon as we touch a bleeding mass will start bleeding, and then we'll see whether it is sensitive to touch, consistency. Ma'am, also we'll see the attachments of the mass by probing around the mass.
What about friability? Whether the mass is friable or not?
Yes, so while probing the mind, if it's a friable mass by manipulation or by probing we might get some bits of the mass may break or might start bleeding.
So where was the attachment? You said you look for the site of
So
attachment.
it was yes, sir. It was attached on the septum anteriorly, and by to probe along the septum, it started bleeding.
So bleeding is a sign of
Bleeding is a sign of what? Bleeding is a sign of what?
if something starts bleeding on touch. So what do you feel in an elderly middle
So the
aged
vessels are
40-year-old male?
So the vessels in the mass are friable and it is not a very formed mass.
Hmm.
Usually
Not friable. What do you mean by
malignant.
if the mass is bleeding? What does it indicate?
It's uh, it's a vascular mass.
Hmm? Vascular means do you think it is hemangioma?
So it can be a hemangioma.
Hmm?
Uh,
Is
so
it
it can
more
be
common in
can be
male or
hemangioma.
female?
So hemangioma is more common in females in 4 to 5 decades.
So what else? What was the other finding on antenasal rhinoscopy?
So the mass was form and consistency, and no other structures on right side on the mass can be visualized because it was uh, and, approaching anteriorly in the vestibule, and on left side there were no specific findings except a septal spur present.
So what do you think this mass is?
Uh, it, Sir, should I go
Problem with our audio and video, na?
differential diagnosis? We'll just check.
It is only on one side. What is the something similar or something? What is the on the opposite side?
Sir,
What is the finding on the opposite nasal cavity?
Sir, opposite nasal cavity, the mucosa was normal. The inferior turbinate and the middle turbinates were normal. There was a sulfur present in the mid nasal cavity, impinging on the adjacent inferior turbinate. The nasal cavity was normal, and the floor was also normal.
Dr.
But
Shirish,
look
is
at the
problem with
mass.
your
Did you
audio?
see the posterior extent of the mass? Did you do the nasal endoscopy?
Yes, sir, nasal endoscopy was done, but sorry, sir, on right side the endoscope could not be advanced because it was tightly fitting on all the on all the sides. On right side, sir, on left side I could do it, and left sir, on the right side I could not advance the endoscope, so only the anterior surface of the mass could be seen.
So what do you think this mass is?
Sir, it could be any sir. So the mass
Can we
is
do
arising
something
from the
about your
septum, so it
audio?
could.
It is not clear to many people. Is there any problem with your
Ma'am,
audio? Because I can understand, but
ma'am,
many
will you-
people are. Just try something if it is there. You can go ahead.
yes, ma'am, actually there are some network issues.
Okay, is it a
Ma'am, am I
benign
audible?
mass or a malignant mass?
Sir, looking at the duration, the external bulge, and also the bleeding, sir, it's suggestive. It can be a malignant mass because any external bulge or deformity can be caused because of any bony erosion, or just it can also be because of um, displace splaying of the bones because of the mass. Sir, it can. Sir, first I'll
Is
give
it
a
playing of bone or is it
malignant.
just bulge on the dorsum or at the lateral aspect of the on the lateral aspect of the cartilage?
So it is a bulge. A bulge. Sorry, sir. It is a bulge due to the mass inside the cavity.
Hmm.
You want
So
us
what
to know
I'm
the
asking is
Sir,
it benign or malignant? What do you think?
sir, in differential diagnosis, I'll first keep malignant conditions, then benign.
What is your differential diagnosis list?
Sir, in malignant conditions, it can be squamous cell carcinoma, adenocarcinoma. It can also be a adenocarcinoma of the
Dr.
marginal salivary
Shirish
gland.
is attached to the septum, you said. So keep that in mind and then tell us the differential diagnosis.
Sorry to
Thank you, sir. Ma'am, arising from a symptom, first we can keep non-neoplastic conditions like right-sided bleeding septal polyp, right, ma'am, can be a hemangioma arising from septum. Uh, Ma'am,
So what was the feel on the probing? Was it firm or soft if you say it is hemangioma?
sir, it was firm and it was firm
Hmm.
inconsistency.
So hemangioma is more common in male or female?
Some females in fourth and fifth decade.
Hmm. Then
I think
Sir,
would we, yeah.
sir, neoplastic patients in malignant conditions uh, can be an adenoid cystic carcinoma arising from the minor salivary glands. It can be a chondrosarcoma, can be a fibrosarcoma. So in the benign conditions, it can be an exophytic type of inverted papilloma which arises from the septum. It can be a chondroma, fibroma. It can be
you
a
think it can
schwannoma.
be inverted
Uh,
papilloma? Is it arises more on the lateral or how does the inverted papilloma look like on
it is
north?
most commonly it, sir, it most commonly arises from the lateral wall. The exophytic variety of papilloma it arises from the septum.
Hmm.
So otherwise, usually it more commonly arises from the lateral wall.
Hmm. So how will you proceed now? You have such a long list of differential diagnosis arising from on one end of the thing you have adenocarcinoma, on others end you have a benign lesion.
Could it be a benign lesion also? What are the benign lesions?
Ma'am, it can be a benign lesion. Ma'am, it can be ma'am, an it can be a hemangioma. It can be
Apart from
exophytic type of inverted
hemangioma is
papilloma.
soft and bleeds. Apart from
Yes,
nasal
sir.
obstruction, is
So,
there a history of bleeding in this case?
uh, only sir on forceful blowing and manipulating on the swelling. When patient used to touch the swelling or used to blow the nose, only then he used to have had the bleeding.
Less likely to be an hemangioma, whatever the history you are telling. So, what are the
Ma'am,
other benign
other
conditions which you want to rule out?
ma'am, it can be a chondroma arising from the septal cartilage, can be a fibroma, or nasal
Have
septal
you heard
schwannoma.
something like
Ma'am,
ectopic minor salivary gland tumors?
yes, sir.
And what is
Sir,
the
it can
commonest
be a
site?
pleomorphic adenoma arising from the
Yes.
minor salivary gland.
So what is the commonest site?
Uh,
Apart from palate, ectopic minor salivary gland tumor,
yes,
what
sir.
is the second commonest thing next to the palate?
It's a nasal cavity.
Hmm. So pleomorphic adenoma of the septum can be there.
So it can be of the arising from the minor salivary glands.
Okay. So how will you proceed now? How will you investigate? You have thought of so many conditions.
So, sir, we'll first go with a contrast enhanced CT scan
Hmm.
to know the extent of the swelling and from also the site of origin. And it will also help us to know any bony erosion or any bony deformity caused. And the external bulge can also be defined by contrast enhanced CT, what is the actual cause. And sir, then we can, so because we also suspect of malignancy, so So we can first proceed with biopsy, uh, and then
Will you do
according
biopsy before
to
investigation or biopsy after radiological
so
investigation?
after, sir, we'll get a contrast enhanced CT scan. We'll get a whole complete blood workup on the complete hemogram and all the other liver function, kidney function test, and all other significant
Would you do
investigations.
CT or MRI?
Then we can proceed. Sir, we sir, we'll
For the
prefer a
site of
contrast enhanced
abnormality,
CT
it
and
is in the septum.
yes, sir.
Hmm.
Sir, if we find any extension or any tap orbit or so MRI is usually preferred for masses uh, extending to orbit or intracranial spaces.
Hmm.
So, sir, we first will go with a contrast enhanced CT scan.
Okay, your choice. Then
Then, sir,
after
the
that,
complete
you'll do biopsy
blood.
or you'll do FNAC.
Sir, biopsy.
Hmm?
Sir, definitely, if by chance the mass bleeds, biopsy can be done under controlled conditions, can be done in OT. So we'll have all means to, have all the, uh,
But say even you
uh,
put a needle in the carotid and press it, it will stop.
yes, sir.
Hmm.
Tell us whether FNAC, you'll prefer FNAC or you'll do biopsy straight.
FNAC, sorry, biopsy. Because,
So you'll do biopsy, excisional biopsy or just biopsy for the diagnosis?
sir, if CT shows a smaller mass only limited to the nasal cavity, and there is no bony erosion. Basically, there are no more signs of malignancy. If it is just a time, according to studies, we can go for excision. But if there are features of malignancy, then sir, before going for complete excision, we should first confirm it on biopsy, and we can plan accordingly the histopathological results.
If the biopsy is a chondrosarcoma, then
So,
what will you do?
um, uh, so, sir, we can go for complete excision, and then we can.
Sarcoma is
Excision
a
means
malignant condition. Sarcoma, soft tissue tumor,
Yes, sir.
which is growing, usually
Yes,
grows
yes,
aggressively. So what
ma'am. Ma'am will, uh, ma'am will check. Ma'am will conduct investigations for any metastasis, and we'll plan for excision along with ma'am chemotherapy and radiotherapy.
and how wide will be the excision?
So, on the basis of
How wide
sarcoma.
will be the excision?
words, what would be your
So,
approach and the area of excision?
ma'am, a small lesion can be managed with
You know the size
endoscopic
now, na?
approaches,
You know,
but yes, ma'am. Yes, ma'am. Endoscopic approaches can, endoscopically it can be excised. Otherwise, we can go for for wide, to get a wider approach, we can go for liquid anatomy.
Okay. And what about adenocystic carcinoma? You are thinking in those terms? How would you?
So, adenosis carcinoma will set spreads very fast to the perineural lymphatics. So, we'll check for metastasis. Will get around abdomen to rule out any abdominal malignancies, metastasis. Then, sir, wide local
How would you
expression
identify the
with
perineural spread? Because that is more in the adenocarcinoma, adenocystic carcinoma.
yes, sir.
Renewal
And which now
lesion.
will you look for?
So,
Hmm?
so we'll check for any. So we'll check for cervical nodes.
So nodes, how will you? Are there any nodes in the neck?
This patient had nodes.
Hmm?
So this patient had no
Your voice is
cervical lymph
breaking.
node.
Yeah, voice is very bad today.
Two?
It could be pleomorphic adenoma as well. Right. So if it is a benign lesion like pleomorphic adenoma, then what would be your plan?
Uh, uh, excision, excision biopsy would be sufficient, and we'll keep it.
No, you said you just now you said you will take biopsy so that you can plan the surgery accordingly.
So,
And now,
so after biopsy, excise the whole tumor. If it's pleomorphic, so excise the tumor
your
without,
voice is
sir,
breaking.
as it is benign,
Hmm.
so
And in case it's a pleomorphic adenoma, then excision would be good enough. And if you have to keep the patient in follow-up because these minor ectopic minor salivary gland tumors, they are known to have malignant change, or they can be mucoepidermoid carcinoma. Again, the patient after excision, the patient should be kept in follow-up. And he should be told strictly that it can recur. So that is what is required. And in case there is a adenocystic carcinoma, again a wide local excision has to be done, and then if there are nodes, the nodes need to be addressed. And patient has to be referred to the tumor board for any adjunct treatment of chemotherapy. So this is most likely a benign tumor and needs to be excised, and patient need to be kept in follow-up. So the question which can be asked in is, okay, what are the other causes of unilateral nasal obstruction, or what are the causes of mass in the nasal cavity? So all those like angiofibroma, depending on the age, at what age the patient is. Younger patient, AC polyp, adult, then polyp or malignancy, intermediate grade tumors like inverted papilloma, and that is the most common tumor which is seen about 35. Patient is 43 years. So we do frequently, occasionally see this mass on the septum, and if it is a pregnant or lactating female, then hemangioma gravidarum is there, and it is um, pinkish mass which can be again excised, and it is all because of hormonal this thing. So what he was saying is that time and again hemangioma doesn't look like this. It's a
Yes.
solid mass, and could be a minor salivary gland tumor or could be some other. So the biopsy will clinch the diagnosis.
Yeah, in hemangioma, there will be more episodes of bleeding, more bleeding, presentation will be different, and because the patient is giving history of 1 year nasal obstruction, and since only 6 months there's a swelling on the dorsum, that is also to be seen, which type of tumors so aggressive, so whether this is a part, whether bone is eroded or not, and if it is a malignant one, then the approach would be different rather than benign. In benign, yes, pleomorphic adenoma may be the common thing. So in this case, because the findings are showing that the mass is attached to the septum, therefore we have to restrict ourselves to the common conditions which are from the septum and not from other parts of the nose. So if there was no history of
Rhinosporosis, Dr. Salesh?
Shirish.
Krish, is it rhinosporosis? Because that is one which is attached to the septum.
I think he will join within a few moments, sir. You may continue the discussion, sir.
So that is a mulberry-like looking appearance and has a unilateral mass, and that is at the where the patient usually nails a nose prick, that becomes the raw surface, and that is the site of attachment. And again, patient presents with the nasal obstruction, and there is a epistaxis. So, and especially these patients, they are from low socioeconomic status, and they usually take bath with the animal, take them to the pond, and at the end of the bath of the animal, they also take a bath, and that is how the spore get implanted. And septum is a common site of rhinosporosis.
Has Dr. Shirish joined again? No.
Not yet. He's joining.
He is from which college? Dr. Shirish is from which place? College?
From
Which hospital?
BPS.
From Acha.
So we had discussed about rhinosporosis also as one of the differential diagnosis. Then what are
It's
the
till the time you will type your questions to our panelists.
The patient is from either from Bihar side or from the south, and the appearance is just like mulberry, irregular surface. That if you have a look of that tumor, you'll never forget it.
so a rhinosporosis on looking or on examination can also show sporangia, that type of look.
Good evening, ma'am. Sorry, ma'am, I lost connection.
Now you are okay.
Yes, ma'am.
Yeah, Dr. Ishwar Singh, you can continue.
So,
Good evening, sir.
how wide will be the excision if it is just your pleomorphic adenoma?
Sir, after histological reports of pleomorphic adenoma, sir, we'll just do a local excision. So because it is a benign condition, we do not need a wide excision. We'll just excise the whole mass, and we'll keep the patient on follow-up.
Will you do open
What
surgery or
would be your
endoscopy?
approach?
Open
Endoscopy,
surgery
open
or endoscopic?
Sir, if possible, we'll first try for an endoscopic approach. But if it's not possible to access the mass completely, then we can go for open approach.
You said that you can perform endoscopy, nasal
Sir,
endoscopy. You don't know the posterior limit clinically.
so posteriorly, sir, on posterior rhinoscopy, the mass was not seen.
No, on nasal endoscopy, the posterior limit of the tumor I'm asking, not on the
So,
posterior endoscopy.
seen. So, yes, sir. According to this mass, the endoscope could not be advanced, so sir, we'll go for a open approach.
Even after decongestion of the tabinates?
Yes, sir.
Tabinates?
Yes, sir. Even after placing small packs soaked in decongest. it was not possible to advance the scope. Sir, in this case, we'll go for a open approach.
So
You will
open
what?
approach means, how will you approach the tumor? How will you approach the mass?
Ma'am, we can go for lateral anatomy using a Moore's incision, and we can approach the whole mass and excise it completely.
You said lateral anatomy, Moore's incision. What is that Moore's incision? Starts where and ends where?
So it starts at the medial to the medial canthus.
What middle to the middle canthus?
So it just starts below the medial canthus, extending in the nasofacial groove along the ala into the nasal cavity.
Hmm. By the way, what is Moore's dictum? You said Moore's this thing. There is something called Moore's dictum also, though it's not related to this topic.
Uh,
You
uh,
just uttered the name Moore. That's why I'm asking you.
so sorry, sir, I don't know that.
Moore's dictum was time to do tracheostomies when you first think of it. And what is modified Moore's dictum? Intubate the patient and then decide. You can make out whether the patient needs tracheostomy or not, so that you can tide over the crisis and then decide whether patient is of head injury or any this thing. So intubate and then decide.
Okay,
So anyway, so you do. Are there any modification of this lateral anatomy incision
uh,
so that this scar is not so prominent and it can be camouflaged? Is there any modification?
sir, sir, for a wider approach, sir, we can. Hello. Sir,
There are modification. You go in between the dorsum of the nose and the medial canthus. Start there. On the lateral border of the on the close to the dorsum, and then come to the nasolabial groove on the ala
sir,
side, and then in the ala it is
okay, sir.
hidden, and then you
Yes.
just decide. So it is just like a hockey stick kind of incision, and not straight what you mentioned along the lateral border of the nose. So there is a
Okay, sir.
modification of the lateral incision. And after that you are done, and you have elevated the flap. Then what will you do?
Uh, so after elevating the flap, sir, in lateral anatomy, after elevating the flap.
Now you have elevated the flap. You have put a suture and stay suture is put. So now your tumor is exposed.
Sorry, sir. So could you repeat, please?
Is
After
lateral anatomy is an operation or is it an approach?
Ma'am, it is an approach. We can, after ma'am exposing, ma'am, we can.
So yes, it is an approach, and the modifications which Dr. Ishwar Singh told you, those can be done. It's just an approach. It's
Yes,
not
ma'am.
an operation. Huh?
so that is
Yes.
just to camouflage the incision mark subsequently, because that scar mark is there, and that is just because there are various subunits of the nasal cavity and dorsum of the nose.
So,
So that incision is given in the on the lateral aspect, and then first minimize the scar part. That was the only point I was trying to make.
so,
So it's an approach. What various surgeries can be done by lateral anatomy?
sir, some medial maxillectomy can be done.
What is
Uh,
the lateral extent of the medial maxillectomy?
Yes.
uh, uh, so the lateral nasal wall, the lateral So the medial wall of the maxilla along with the lamina papracia.
I'm
What is the
asking what is the
lateral
limit
extent? Lateral
of the
extent.
bony excision in a medial maxillectomy?
Lateral extent of,
You said a medial maxillectomy can be done by lateral rhinotomy approach. So the question is, what is the lateral limit of the medial maxillectomy?
It is medial maxillectomy. So what is the lateral extent?
move the
How much
medial.
maxilla?
We'll just remove the medial wall of
Still,
maxilla.
but you have to have a limit, no extent.
Ma'am,
अरे भैया तुमने मीडियल वॉल निकाली ना, सिर्फ नाक का लेटरल वॉल निकाल के काम चल जाएगा क्या? यू हैव टू रिमूव एनी मोर देन दैट, एंड व्हाट इज द लेटरल लिमिट ऑफ दैट रिमूवल?
so we'll also remove the lamina papracia.
Lamina
The
papracia.
answer is infraorbital foramen is the lateral limit. Up to that you can remove that it becomes a part of the excision in the medial maxillectomy.
Do you remember we always tell you when you raise the flap that you have to only raise the flap till infraorbital
No,
foramen
yes,
or
ma'am.
no? So that is the lateral limit of medial
So
maxillectomy.
part of the anterolateral wall of the maxilla is also removed with the medial wall. What you are just focusing on the medial wall.
Yes,
What
sir.
is you can do? Medial maxillectomy by lateral rhinotomy. What else can be done?
Sir,
That means what are the other things?
ma'am, lateral.
You said because we said that it is an approach. So what are the other things? What are other operations?
Ma'am, 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 the other surgeries which can be done.
Hmm.
Ma'am, it can be, ma'am, lateral anatomy can be used in.
It is a part of other operations also. It is part like.
Sir, excision of the inferior inverted papilloma.
So that is medial maxillectomy.
Yes, sir.
Don't we do
Okay.
angiofibroma by lateral rhinotomy if it is limited angiofibroma?
Can we do it, Shirish?
Actually, sir, you're not
Yes or no?
audible, sir.
Can we do a limited angiofibroma excision by lateral rhinotomy?
Yes, ma'am.
Yeah.
Ma'am, approach the maxillary antrum and ma'am through lateral rhinotomy and ma'am it can be used for limited angiofibroma.
Yes, it can be used.
So
In your findings, you had told us about that patient is partially edentulous.
Yes,
So,
ma'am.
is there any importance about the dental status or dental condition? Why do
Ma'am,
you?
in
Hmm.
cases of any maxillary pathologies, whether ma'am infective pathologies or malignancies, ma'am
Malignancies, yeah.
patient can have pain, dental pain, loosening of teeth.
And
Patient
loss
can
of teeth.
have or heaviness over the lips or teeth.
Or loss of teeth also.
Yes, ma'am.
So, in addition to writing that patient is partially edentulous, I think you should write the dental formula,
Okay, ma'am.
what
right?
is dental formula?
Yes, sir.
What is dental formula?
Sir, we'll sir, So all the numbers of number of
How do you,
teeth, sir, starting from the
how do you
incisors and
write? I've
canines.
told you many times. How do you write? A cross is
So
made. What? How do you
a
write?
cross is made, ma'am, and then superiorly, ma'am, the left side and right side is written. If there is some teeth missing, ma'am, then that number is skipped,
Hmm.
and we can also mark if some teeth has caries.
So,
Uh,
what is the normal dental formula if all teeth are there in an adult?
ma'am, ma'am, one. Ma'am, superiorly, 1, 2, 3, 8 on the left, 1, 2, 3, 8, 1, 1, 2, 3, 4, 5, 6, 7, 8 on the right,
No,
and
no, no, no,
similar.
no, no, no. Canines, incisors, premolars, and molars are depicted separately.
Yes, ma'am.
So,
Ma'am,
two,
two incisors on,
uh,
ma'am,
Two
two
one two three.
incisors, one canine, ma'am, two
mhm,
premolars, and a
and
molar,
and three
like
molars.
that we can label it.
Two one
Yes.
two three.
2, 1, 2,
Yes, sir.
3. Exactly.
Yes, sir.
So, if you are talking about maxillary sinus or even for mandibular teeth, in case of
Ma'am,
malignancies of oral cavity, or if there is a possibility of or suspicion of mandibular invasion, and we're talking about teeth, dental formula
ma'am,
is very important out there, right?
ma'am.
Was there
Okay.
any bulge on the palate, or there is anything on the palate? Palate was normal in this case.
Yes, sir. Palate was completely normal. The gingival buccal and gingival buccal sulcus was also normal. No bulge was present.
Hmm. Can this swelling or this lesion extend to the palate also?
Uh, so you're asking, can it extend to the palate?
Yes. Had there been, what would you have been in the presentation if there was a palatal involvement?
So palatal involvement, there can be a bulge in the palate,
Hmm.
gingival buccal sulcus. The
It is a
patient can also
bulbous
have
sulcus, or it will
ulceration
be the
over.
midline. Septum is a midline structure, so it is.
So,
Hmm. So is it gingival sulcus, or it will be in the midline?
sir, it will be in the, sir, yes, sir, it will be in the midline. So there will be a bulge in midline.
Hmm. So
Sir,
there
in
can be
Could be in
ulceration
the
depending
midline,
on the
could
if
be
it
on
is
the
there
one
can
side.
be
malignant or benign.
ulcerations.
Hmm.
Yes, sir.
So how would you suppose you have to do an X-ray, though you have
So,
already done CT scan? What kind of
so.
X-ray would you do to see that whether the palate is eroded or not? Those dental people do it, and where
Palate.
the film will be kept, and how will you do the X-ray to see the palate?
So, so X-ray. So X-ray, I don't know.
You want to take an X-ray of the palate, whether there is some cyst or something like this, or
So,
this lesion has extended to the palate. So, can you assess it by radiologically other than CT scan?
sir, in dental, sir, they do occlusal X-rays, so that can be done.
So, where do they
Plus,
keep the film in occlusion?
sir, between the teeth, sir.
Yes, yes,
Uh,
yes. Okay.
Between the teeth.
so upper and lower jaw, patient is made to keep the film between upper and lower jaw,
Huh?
upper and lower
Well, just
teeth,
hold it
and
in the
then
teeth.
yes, sir.
No, it has to be supported with thumb and capped firmly against the palate. So the film has to
Oh,
be close to the palate, not
okay, sir.
over the in between the teeth. You open your
Okay,
mouth,
sir.
put the
So,
plate on the under surface or on the palate and support with your thumb, and then the X-ray will be done.
so,
This is how they'll do, like your nasolabial cyst, or you have some ectopic minor salivary gland tumor. So you want to see whether the palate is eroded. So that is the way they do the X-ray. But now with the advent of CT, so all those things have
so,
become history.
so.
So we were talking about, I think, perineural invasion or something like that, if it is a minor salivary gland tumor. adenoid cystic
Yeah.
carcinoma or mucoepidermoid. And then we're asking you whether the CT is better or some other investigation. Is it CT only?
Ma'am, we'll go for MRI.
MRI, you had
Contrast
answered?
enhanced
Okay,
MRI.
okay, okay, right. Anything else? Okay, you were talking and from where did you get that terminology, controlled probing? Do you have any
What is
reference
Ma'am,
for that, or it is a gentle probing?
ma'am, actually, I took it from some examination performer.
Or forma?
It's something like controlled probing.
Even I told him
Ma'am,
that.
I'll correct that.
So just say because there's a history of bleeding, so it should be a gentle probing. Control probing is
Yes, ma'am.
not a word, I think. Anything else?
Yes, ma'am.
I think that is good enough.
Mm-hmm.
Already 7:10.
Thanks.
Yes, so thank you. Well, thank you very much, Dr. Shirish, for the
Thank you.
presentation.
Thank you.
Thank you very much, Dr. Umar Garg and Dr. Ishwar Singh for joining. And thank you,
I
trainers and
went
faculty
a bit
members for
late.
joining.
I was coming. I was driving.
You were stuck in traffic, it seems.
Yeah.